Once upon a time in the VBAC group, there was someone who came on and she said, okay, I understand that I am not a good candidate for a VBAC, but I really want my doctor to give me a chance. I don't want to be told no straight up. She's like, I want a chance. I want a chance to trial. I'm sorry, I want a chance to labor. And then if it doesn't go well, then we can proceed to the C-section. And she's like, how do I convince my doctor to go ahead with this plan? And I said, well, you got to see it from the doctor's point of view. They have someone who has a low chance of success, and they're worried that what you might do is say, oh, I want to have a trial of labor. And then when the time comes and you say, okay, we've tried it, things are not going towards a vaginal birth, so it's time for the C-section, and only to have their patient say, no, because you have to consent to a C-section. So there's a chance that the patient might dig in their heels, refuse, and things start going towards a very unpleasant emergency section instead of a nice plan section. So I said, well, you could say, I understand my success rate is not great, but if all the stars align, then I might be able to get it. So to try to convince them that honestly, if you say C-section, I will say, okay, I'm ready for the C-section now. I've had my chance. How would you handle that, Dr. Levy?
I think that's a pretty easy thing to do, because if you have everything completely written out and discussed ahead of time, like the details, like, okay, I don't think your chances are high, and this would all be in writing. This is the percentage chance that I think that you have based on your past history and what happened last time and what's happening now. And here's the road that we're going to take. So there's only a couple of choices. Like if you don't go into labor by X date, and for me, I would pick a date in the 39th week. There's no benefit to waiting. If you're 39 and 3 and waiting till 40 and 1, there's no benefit in that period of time if you're completely not in labor. There may be benefit if you come into my office at 39 and 3 in a little bit of labor and you're like 2 centimeters dilated, then the person might say, give me some more time to get into better labor. But to that, I would also say, why? This is the time to augment your labor. So I would pick a date in the 39th week, write it down, have them come in, sit with me and go over it. And this is the plan. If you're not in labor at all, this is what I can offer you. A balloon, this amount of time with the balloon, and then Pitocin, starting either with the balloon inside, depending on what your dilation is at the time of the placement of the balloon, or balloon first and then sequential Pitocin afterwards. I would put it in there. This is the amount of time that I would allow this to go on, and this is the type of change we need to see over this period of time. And it's and something reasonable. I'm not going to say if in 6 hours you're not ready to deliver, we're throwing in the towel. No, talk to them about what's normal progress for somebody who's going into labor at this point. So if you make it to active labor and you're 6 centimeters dilated, I expect you to dilate this much per, it's not really per hour, but over a period of time, over the next 4 to 6 hours, you really need to be this much dilated. And all the criteria underneath that. Baby has to have what we call a category 1 tracing. It has to be reactive and reassuring. We don't see meconium. There's a lot of things that have to go in there. And if that person can follow those criteria through, I have no problem continuing the process. But there also has to be an endpoint in there that you would agree on, that if I went to this point, whatever you guys decide, maybe it's 24 hours, whatever, how many hours, and no progress has been made at all in a 4-hour window, and you're not ready to push the baby out, then we agree we'll do a C-section before it becomes emergent. And they sign that, and they talk about it, and they have a copy of that on the chart, and then they follow that. I think the problem comes exactly what you said, where we agreed on one thing and then things change and everybody changes their mind, so they weren't clear, or the shift changes and there's a different doctor that comes in who's not as comfortable with whatever the plan was. And that gets confusing and that gets upsetting to the patient, and they feel like their wishes are not being honored. But if the plan is clear and all people involved are in agreement, and then it follows to the point at which I've had patients say to me, okay, I gave it a try. I don't want to keep going anymore because I can see what's going to happen, and I'd rather have the section while I'm not bleeding and there's no meconium and the baby is fine, and the baby will probably do okay. But I really think it's all, just like all of delivery, I think it's all about expectations and planning, and then sticking to it while you're having conversations with your patient, because that's the complaint about most people who are complaining. Somebody didn't listen to me. That's the complaint, right? So I think don't go there. Don't let them be able to say that, and you will have a successful outcome, whether it ends up as a section with somebody who tried and not failed, but just it didn't make it there, and or somebody who does make it there. Great, you know.
Good.
Can I ask what category 1 is for the
Category
baby?
1
Did
tracing.
you mention category 1? I don't know the name. So.
We used to have terminology that we used that was like reassuring, non-reassuring, variables with a late component, all these things. Now, nursing care in the delivery room is all standard. You either have a tracing that's category 1, category 2, or category 3. We'll go back from a third. Category 3 means this is a baby in jeopardy. You need to get that baby out now. The baby's going to lose oxygen, immediate either C-section or instrumental delivery, whatever it is, needs to come out now. Category 1 is everything looks reassuring. We have criteria. It has to have a certain number of accelerations. The variability has to look a certain way. There's nothing suspicious happening there. There's like a list of 10 different things. That's the tracing that we want. We're watching someone have labor contractions. The baby doesn't care. You know, it's very reassuring what's going on inside there. There's no acidosis. You can be reassured that this is a normally laboring person. Category 2 is somewhere in between that. So it's like, things are happening. This is a baby that you might start to think about, how am I going to get this person delivered? If I have a category 2 tracing and you're 1 centimeter dilated and it continues to be that way, my inclination is let's get the baby out before it turns into a category 3 and we're in an emergency situation. So it's kind of like, if you can't change things within 20 to 30 minutes and make it a better tracing and go back to a category 1, you have to pull out your, what do I do? Change position? Do I give fluids? Do I stop the Pitocin if she's on Pitocin? There's a lot of different things. Like you come out with your, what can I do to make this tracing better situation?
Thank you for answering, because I didn't know anything about that, but I love that because I think a lot of people during labor don't understand what they're looking for when it comes to your baby. It's not just you, but we want to make sure baby's good, you know? So I love that you explained it like perfectly.
Yeah. The more standardized it is, the more understandable it is. Because when I go in and I see a tracing, like, you know, we have central monitoring. So a patient might think we're not seeing what's happening on the tracing, but I see it from the front desk. And if it's category 2, I'm going into that room and going, okay, things are changing right now. I don't like the way the baby's responding to your contractions. So here's the things we're going to do in order to make it look better and know that you still have more time. And sometimes category 2 goes on for a while because you got a narcotic, because you're in pain. So you got some fentanyl or something. The tracing goes to something that doesn't look reassuring, but it's not because something's wrong with the baby. Suddenly you got a drug. So you're expecting to see that for a little while until the drug wears off. Then if it doesn't, you have you have to look for the other reasons. So that's how we, you know, when I used to train residents to walk around, we would do like making the rounds in the delivery room and look at everybody's tracing. The first thing that I would ask them is like, okay, look at that tracing. Tell me how I know this patient can continue to labor. How do I know that I shouldn't be doing something about her right now? And they better know.
Okay, I have a question, and it's on communication. And I see this in the VBAC group, and it's where they frequently people are surprised when their provider comes up like 25, 26 weeks and says, okay, let us talk about how you're going to deliver your baby. You know, if they're going to schedule a section or various other things, induction, non-induction, that kind of thing, how far you're willing to let the patient go. And two things happen. One, people are surprised and they're not ready to have that discussion, although I think it's really important to have the discussion as soon as is reasonable. And two, they immediately have questions. Why won't they let me go to 41 weeks? Why do they want me to deliver at 38 weeks? And then we say, well, what's going on? And then maybe there's IVF, maybe they're advanced maternal age, maybe they had problems in previous pregnancies. How many times should you have the conversation, before 39 weeks rolls around? Because I tell my son when he's learning stuff, I said, read it once, read it twice, read it 3 times, because that's how our brains work. The first time doesn't necessarily stick.
Yeah. I think because you take care of somebody for 9 months, you have ample opportunity to have multiple discussions about this. I usually ask on the very first visit, if somebody has had a C-section before, have you thought about how you might like to deliver this baby? Because I like to note that in the chart so that I don't, if somebody just tells me, oh, I want a repeat C-section, I'm not wasting my time talking about the risk and benefit of a VBAC if they're not interested. I'm not here to convince somebody to do something that wasn't in their head. So at the very first visit, I ask, what was your plan about how you're going to do your delivery? And about 50% of them are really sure about what they want, whether it's a repeat C-section or I really want to try for a VBAC. The other 50% are more like, I didn't really know there was a choice, because people have said to them, once a C-section, always a C-section. Or somebody said during their last C-section, you better never try for vaginal delivery. So they have an idea in their head what it was supposed to be. So I ask, what was your desire? So for the people who want a repeat section, that's easier. We start talking maybe at about 29 to 32 weeks about when they might like to do it or what my opinion is when to do it, because that's a scheduling thing. Like right now, I have 3 people in the month of June who are going to have C-sections. So I'm scheduling them now because I want the time that I want and the time that they want. They can pick their baby's birthday as long as it's within, a reasonable time in the 39th week. So those are the easiest ones. People who want a VBAC and people who are not sure, those are the people who need multiple conversations. People who absolutely want a VBAC, first thing I have to do, and I'm glad that I saw them at a first visit to ask them about that, I need their records. I have to look at what happened last time, because I'll ask them what happened, but that doesn't always go along with what I'm going to read in the records. They may think something happened, but it didn't, or they may think something didn't happen, but it did. So I want the records. So once I read the records, then we start having the conversation about how realistic it might be or not be for them to plan a VBAC. And we do that. I don't say I mention it at every single visit, but once I've gotten a look at the records, if I have a reason to dissuade them from a VBAC, like this looks like this will be a repeating issue, this is a person who never should try for a vaginal delivery, whatever it was, a classical incision or something that really doesn't lend itself to VBAC, then I really need to kind of talk to them about how I would not support a VBAC because that would be an unsafe choice, et cetera. What most people who want a VBAC but are unsure if they can do it, they need the conversation about 1, what happened last time, 2, how likely is that to happen again, and 3, what are the risks and benefits of trying for the VBAC and how much do we quote unquote try? So I really have a very detailed conversation somewhere before 32 weeks, giving them all the information, talking about risk and benefit, because 1, if it comes to a point where we don't agree, like I think it's unsafe completely to do it and they want it, I'm not going to do something unsafe. They can go look for somebody else at that point, because I'm not going to say, okay, just because somebody wants. Most people, it's not unsafe, but unlikely are many of the other ones. And, we do a calculator. We kind of say, if your baby was breached last time and you never labored, you don't know if you can have a successful VBAC. So if that's something you really want, here's my plan for VBAC. Here's how long I would let you go. Here's what I have to bring labor on if you're not in labor. And here's how we need to have a conversation about what will actually happen in a VBAC situation and why you need to be in the hospital from very early on, and what is the risk, what would happen if you did have a rupture, what's the percentage that might happen to you. So all of those conversations need to happen mostly for people who either really want a VBAC or who are unsure what they want to do. And then the unsure people, some of them will just, after they hear that conversation, they go, not worth it. I have another baby. I don't want to have a problem where I might end up with a rupture or some kind of problem like that. And they sign on for a repeat section. And some people who want to VBAC and are good candidates, which now we've weeded out from so many that started off at that first conversation, people who are good candidates or decent candidates and want it, then we have the really deep conversation about risk benefit and how it's going to go. And for me, it's always in the 39th week, mostly because that's the time that a baby is most likely lung maturity and you have reserve in your placenta. And I explain that to them. So, do it early enough so that if they don't want to come to me for the rest of it, they can go elsewhere, but late enough so that we're starting to make plans.
Okay, I have a technical question. That's a medical question. And it is, you have a patient who has severe preeclampsia to the point where they need the magnesium, mag sulfate, and you induce them. Now, here's the thing. Mag sulfate tends to relax your muscles, and so induction doesn't always work. I don't get how those two things interplay. Can you explain it to a layperson? If you have preeclampsia and you're in the hospital hooked up to IVs and they're like, yeah, we're going to douche you, exactly what's going to go down?
If you're talking about a VBAC person, that's a different situation. If you're talking about just somebody has severe preeclampsia, number one, if they made it to 37 weeks, that's the time for the induction on that, because hypertension and severe preeclampsia should be induced early or delivered early. And it is true, magnesium is an exact opposite of like Pitocin. If you could have someone on mag and PIT at the same time, and they are kind of working against each other. However, preeclampsia makes the uterus more sensitive to contracting. So believe it or not, people with preeclampsia tend to not need as much Pitocin to deliver it, and once they go into labor, it usually cascades. And if they're a good candidate, if they're in good labor, active labor, they'll probably deliver. And to tell you the truth, I'd rather deliver someone vaginally who's on mag than section them, because mag not only does it relax your whole uterus, relaxes all your blood vessels, and you're going to bleed like stink. So a section is really a bloody mess in someone who's on mag. Sometimes we even turn it off while the section's going on, figuring that the anesthesiologist can control for their blood pressure and everything else while the section's happening, and then turn it back on afterwards.
Okay, because I understood it was tricky, but all the first person accounts I was getting from people, well, I couldn't quite get a clearer picture. That helps so much to know that pre-E tends to make your uterus kick big time.
And it also makes it respond more to a really good strip. If you strip their membranes really hard and they're preeclamptic, that's lots of oxytocin coming out of that cervix, lots of prostaglandins.